This is Pain Management in Children from Essentials of Pediatric Nursing by Kyle and Carmen. This is just a little picture reminding you about pain. If you remember, you've got the peripheral nervous system as well as the central nervous system. And when you do something like put your hand on fire, those nociceptors out in the peripheral nervous system are triggered, and then they cross over into your fastest nerves in the central nervous system that cause that reflex, that pulling away before your brain processes, wow, that was painful, I should move my hand. Some things don't have that immediate response sending back a nervous impulse, that they go up to the cerebral cortex and you have to think about, what am I going to do? I think I'll move my hand. But pain is reflexive and makes you pull away. So, classification of pain. There's different ways we can classify pain. By duration, we can call it acute or chronic. By etiology, is it nociceptive, so it comes from the peripheral nervous system, or is it neuropathic, which means there's something wrong with the nerves themselves and the nerves are triggering the pain, where in the nociceptors, those are out in your tissues. Or we can describe it from its source or its location, somatic or visceral. Is it just in the tissues or is it deep down in your some sort of organ? Things that influence pain: age, gender, cognitive level, temperament. There's studies showing all of these things do have an effect on how you respond to and how you express pain. Previous pain experiences, and then family and cultural background. So here's some myths, and I've heard most of these, that newborns don't feel pain. Well, that is not true. The whole nervous system of feeling pain is well intact before they're born, so they certainly do. That pain at an early age has little or no effect later, and that's not true. We find from studies that we do need to control pain in children because it does affect them, and they may not, the next one, that they don't remember it, they do remember it, and even if they don't, they develop that response, and they're kind of subconsciously remember their response to pain, and will usually overreact to pain because of it. So that if they're sleeping or playing, they're not in pain. Sleeping, there may come a point where they're just so worn out, they do sleep. And playing, kids are better than the rest of us at distracting themselves. So they can look like they're not in pain because they're playing and having a good time. All of a sudden, that distraction is no longer adequate. So they look like they go from no pain to severe pain because the pain level surpassed what play could distract. So they did suddenly go from none to full pain. It doesn't mean that the pain isn't real. The children are truthful, and no, they are very likely to not tell you the truth because they don't know what you're going to do. They're afraid of what you're going to do if they tell you they're in pain. So trust what they tell their parents or what their parents say. If the parents say this is the way they act when they're in pain, then they're probably in pain. The children learn to adapt to pain and painful procedures. Not really. They still hurt, and the more we can treat it, the better. The children are very prone to addiction with narcotics. Not true. Just like anyone else, they'll develop a physical addiction if we have them on a lot of narcotics. And just reassure your parents that's a totally different thing than psychological addiction, and there really is no connection between the two. It just means we've got to wean them off so they don't go through physical withdrawals. So, what are we going to see in an infant who's in pain? Well, we're going to look at the facial expressions and body movements, crying, irritability. They might refuse to move a body part, or they don't sleep well. So, behaviorally, that's what we're looking at. Some of the physiologic changes we're going to see is a change in the heart rate, but in those preemies, it may go the other way, and that's farther down. It says vagal tone. The vagal nerve controls all these things, and sometimes they just react differently than we would expect them to. So their heart rate might go up, but on preemies it may go down. You're going to see those facial expressions. Respiratory rate, again, should go up, but you never know what a preemie will do. They may stop breathing on you because of pain. Oxygen saturation levels usually will drop a little because they've raised their metabolic rates and they're needing more. That vagal tone controls these autonomic responses, and then plantar and palmar sweating. And here's a picture of a baby in pain. Notice the scrunched eyes, the furrowed brow, the mouth kind of wide and sort of squared. So when we move on to our toddlers, when they're in pain, think about what you say. They are not going to understand, what's your level of discomfort. Use words that they do understand. Probably owie and boo-boo are really common words. Listen to what the child and the family say and use those terms because they don't know your terms. Preschoolers, these guys may not want to talk to you about their pain. And sometimes this group may feel like they're at the hospital. This is what happens there. They may not realize it can be treated. School-age children, we finally are where we can let them do self-report and they make sense. They can tell you the type, location, severity of their pain. But again, remember, they may not be honest with you because they may be afraid of what the treatment's going to be. Teens often want to look tough and will say they're not in pain or that they don't need medication. So explain to them those stress hormones are going to slow down your healing unless we keep your pain under control. So their big concern is body image, fear of losing control, being out of control, and just part of that wanting to look tough to their peers. So some things that affect how children respond to pain is the type of pain and the extent of the pain, and then their age and developmental level, and the cultural and family norms. If they come from a family where they're told, quit complaining, buck it up, they're not going to be as expressive of their pain as a family who, every time they fall and skin their knee, comes, oh, poor baby, oh, right? That kid thinks it's appropriate to cry at minor pain, where the other one is not going to cry even at pretty significant pain. And then, that kind of fits within American culture, both of those responses. So add in other cultural responses and views of pain that, maybe they're seeing this as a spiritual issue, a spiritual battle. Maybe they're very afraid of anything that alters the mind, like pain medication. So you've got to take all those things into account. So I like our book uses these principles for assessing pain. You can use the word quest with a double T though. So question the child. Make sure you're using the right tool, a reliable and valid pain scale, but one that's appropriate for the child's age and development. Evaluate the child's behavior and physiologic changes. Behavior and physiologic changes on kids, let me just warn you, it's hard to know, are they in pain? Are they mad because the parent just left? Are they frightened because you tend to hurt them and you just came back in the room? So it's really hard to use an infant's behavior we can look at, but an older child's behavior and physiologic responses, it's really hard to separate pain from any other stress response. So we do want to look at that, kind of get those baselines. So especially if we give pain medicine, can we see a difference? But you got to be a lot more cautious on using physiologic measures on kids than you're used to with adults. So, secure the parents' involvement. Parents will tell you what they act like when they're in pain. And they'll tell you, yes, this is how they act in pain, or no, this is the way they act when they're tired. They need to go down for a nap. We can't know those things if we don't know the child as well as the parent does. And then take the cause of the pain into account. If they've just had surgery, we're going to expect a totally different type and intensity of pain than if, they tripped and skinned a knee. And then take action. What do you need to do? So, history of the pain. Let's find out what we can. The location, quality, severity, onset of the pain, the circumstances where the child experiences the pain. Do they only have this pain when they're doing a certain thing? And you'd be surprised how people don't connect the dots. And often when we start asking questions, they go, oh yeah, it only happens, in this setting. So what happens before the pain? What happens after the pain comes on? What either makes the pain better or worse? It increases or decreases the pain. Have there been associated symptoms? Did the pain start when the weight loss started, or the fever, or the vomiting, or the diarrhea, or this current illness? Again, people don't necessarily make the connections. So we need to help them do that. Was there a recent trauma? Maybe the child's in for surgery, but they're complaining about their elbow, and then you find out, oh, they fell at school yesterday. That's what the elbow's about. So, it has nothing to do with the surgery. And what has been tried and what worked. And let's try what works for them. So there are a number of pediatric assessment tools in our book. However, for me, I only test you on the faces, the Baker-Wong faces, and on FLAC, because those are the ones and then 0 to 10, because those are the ones we use at Valley Children's. So when you're ready for NCLEX, you probably want to review the others, but I don't test on them. So Baker-Wong, you can start using this about age 3. It's designed where you can either do 0 to 5. At Valley Children's, we do 0 to 10, so every scale we have is 0 to 10. So the pictures are 0, 2, 4, 6, 8, 10. They do recommend you use the words that are given there. It hurts, there's no hurt, it hurts a little bit, hurts a little more, hurts even more. We don't want to use terms that the child doesn't understand or that are frightening to a child. Some of those words that we use that they don't know sound really scary. So try and use these words. If the child doesn't understand them, you may need to adjust them a little, but still try and use simple words that the child will understand. And then, so the other one we're going to use is the FLAC down there at the bottom. And that one we're looking at, the F stands for face, and here's a nice face in pain. The L is the legs, A is activity, C is cry, and the last C is consolability. And I have a link there if you want to look at a baby crying and see what you think. But 0 means no problem, so happy face. 1, it's kind of on and off. 2, they're doing that and not stopping. Legs, 0 is they're kind of swinging things around, nice, easy movements. 1, on and off. 2, they're either pulling their legs up and staying stiff, or they stretch them out and stay stiff, but it's not that gentle, fluid movement. It's pulling in and then stretching out. So activity, do they, again, that nice, just fluid movement? Do they act like they're kind of uncomfortable and then they're okay and then they act uncomfortable? Or does nothing get them comfortable? Crying, not crying, intermittent, crying all the time. Consolable. You pick them up, they stop crying, they're consolable. It works a little bit, but not always. Nothing you can do to console them. So you give a 0, 1, or 2 for each of those, add them together, and you've got a score between 0 and 10. And at Valley Children's, we use that on all infants and all children who are nonverbal. So you may have somebody who is very older but very delayed, and they can't give you an answer to the faces or a 0-10 answer.